So I think we can make a start so that we are on time. So welcome everyone, and thank you for joining us today. My name is Fotini Telu, and I work as a research associate at the Wolfson Center for Young People's Mental Health. It's my pleasure to welcome you to today's lecture, which is part of our public lecture series. This is the third and last one for 2024, with the first one in 2025 taking place on February. So the lecture is going to be recorded and will be posted on the Wolfson Center YouTube page, where you'll also be able to see any other talks in the series that you may have missed. This session is scheduled for an hour, and questions and discussion are encouraged. So please post your questions via the Q&A box, which you should be able to see at the bottom of your Zoom screen. Our speaker today is Dr. Aideen Maguire, who is a trained psychiatric epidemiologist and is currently a reader in the social epidemiology within the School of Medicine at Queen's University Belfast. She's a director of the Administrative Data Research Centre, or ADRC, in Northern Ireland, and runs a team of research specialists from Queen's University Belfast and Ulster University, who are focused on delivering high-quality, impactful evidence that supports policy and practice in Northern Ireland. So today's talk specifically will focus on what can administrative data tell us about mental health, self-harm, and suicide in Northern Ireland, and how they can help us inform policy and practice. So over to you, Aideen.
Perfect. Thank you, Fotini, and thanks for the invite to speak today. Hopefully you can all see the screen okay, and let me know if there's any issues with sharing, but I'll take no news as good news and carry on. So, like Fotini mentioned, I'm going to speak to you today not about one particular piece of work, but about an overview of a range of different papers that we have published that are around the focus of mental ill health, self-harm and suicide in Northern Ireland using administrative data. And I thought I would start just with a little bit of a focus on what administrative data research is, who we are and what do we do, because it might seem a little bit removed from the sort of hands-on intervention research and removed from the sort of practical problem solving research and help that you guys at the Wolfson Center hope to provide. But we can use data to help develop our understanding of the causes of, or predictors of, or trends of depression and anxiety in the population, or in our case, self-harm in the population or death by suicide. Or we can use administrative data to evaluate a particular intervention or strategy change. So at the Administrative Data Research Centre, our aim is to make the best use of data that's already collected for the provision of services. So by administrative data, we mean this sort of routinely collected data that's collected from our health professionals, or our GP practices, our hospitals, emergency departments, or data that's collected from schools about educational attainment, from the census, from HMRC income data, data about poverty, data about benefits receipt, data about interaction with all kind of government services that you can imagine. And these data tend to be collected for each particular service in isolation. And then they present lovely annual reports about it, and then it goes away. But the Administrative Data Research Centre in Northern Ireland is part of a UK-wide consortium that's made up of universities and government partners who all have the same aim, which is to make available this abundance of government data that's collected for the provision of services to accredited researchers in order to use this information that we already have to better understand sort of population health and inform services and policy. ADR Northern Ireland is a partnership in particular between the two major universities in Northern Ireland, which is Queen's University and Ulster, and our National Statistics Agency, NISRA. ADRC in particular are just the university partners. So ADR Northern Ireland is the partnership between the universities and our government departments. ADRC are the academic researchers, and I'll be presenting research results from some of the work that our team has done. The mission of ADR UK and of ADR Northern Ireland, like I said, is to join up the abundance of administrative data that's already created by government and public bodies across the UK, with the aim to sort of make it available only to approved researchers in a safe and secure way. And the important thing is that it has to be for research that will inform policy or practice, not just research for research's sake. Now, my research focus, as Fotini mentioned before, is mental ill health. I'm a psychiatric epidemiologist, but in the work that I'm doing at the moment, the focus is to use administrative data to better understand population mental ill health. I'm going to be presenting work that focuses in particular on deliberate self-harm and self-harm or suicidal ideation, and to understand the association between these behaviours and death by suicide, and also to sort of close the loop looking at to better understand how thoughts about self-harm and taking your own life can be associated with deliberate self-harm acts, and how deliberate self-harm itself is associated with thoughts about taking your own life. Now, our research also does use administrative data to examine things like depression, anxiety, and severe mental illness, and how these are associated with one another. And today I'm not going to be talking explicitly about any of these outcomes, but depression, anxiety, severe mental illness, we know are all interlinked and associated with deliberate self-harm and thoughts of self-harm, and of course with death by suicide. So hopefully, although the research focus is a little bit not focused particularly with depression and anxiety, it will add some value and insight into some of the work that you're carrying out yourselves. So of major public health concern right now in Northern Ireland is self-harm and suicide, and Northern Ireland has one of the highest rates of death by suicide in the UK and Ireland. And while rates haven't been sort of starkly increasing over time, we are seeing the profile of those who die by suicide change, and we are seeing rates of self-harm and suicidation, which are known precursors to death by suicide, increase dramatically. And this has been all over our news recently. We have a range of different strategies that we implement, such as towards zero suicide, or roll out these interventions. But the degree to which these are evaluated, or how much we can show if these strategies or interventions have really worked, is really unknown. We rarely see in the news, this strategy worked and we've seen a reduction in deaths by this much. What we need to know to understand if these policy and practice interventions work, and how this is reflected in terms of what we see on the coalface in terms of primary and secondary care services. So the aim really of our research was to use administrative data to help us identify individuals that are presenting with self-harm and suicide in Northern Ireland, to understand the patterns of these and to understand how some individuals in this group will go on to take their own life and some won't. And this falls into a larger package of work within ADRC, which is to help use administrative data to identify previously underserved groups. So previously underserved groups and groups that are difficult to include in research include individuals who have mental health issues or who are suicidal, because it's difficult to engage these individuals in primary research or engage them in survey research. But we are able to somewhat use administrative data to identify these individuals, and that's what we attempt to do. In order to better understand who in Northern Ireland is dying by suicide, who's presenting with self-harm, who's most at risk, who's least at risk, who may benefit from interventions, and can we see any trends and how this has been changing over time, we have examined linked population-wide data, looking at things like death registrations, primary care registrations data, interaction with health and social services, so social services data where children know into social services, census data, prescribed medication data. We have a Northern Ireland registry of self-harm, which contains information on all individuals who present to emergency departments with self-harm or thoughts of self-harm. We have other general emergency department information to see if individuals are presenting with other injuries. And all these data are linked via the Administrative Data Research Service, using the 5 safes to ensure the data are anonymised, made safe, and available to only accredited researchers. So we haven't linked all of these particular data sets together in one entire project. What I'm going to be presenting to you today are results from projects that have linked different iterations of these linked data sets. So one project just looked at census data linked to prescription medication data linked to death data. Another project looked at all of the health data that we can see here without census data. And another project just looked at self-harm and prescription medication data. So we have a number of projects represented here today. I hope you find some of this interesting. I'm going to just jump to the good bit now and tell you some of the results that we have and some of the key findings from about 5 different papers. What we've done with these findings is put them together into a policy brief to show the strength of administrative data and what that can tell us about population mental health in terms of self-harm, ideation behaviors, and risk of suicide. So I'm just going to jump straight into this, go through some of the results, and at the bottom of each slide, you'll see the paper that it relates to. So if you want to have a read of those or find out anything in more detail about the methods or data used for it, you can take a look at the paper in more detail. Result 1 is living with a parent with mental ill health increases the child's risk of suicide. So this was a study using census data linked to mortality data. And what we found was that in Northern Ireland, 1 in 8 people are living with parents with poor mental health. This doesn't just relate to children living with parents, but also adults living with parents as well. Children living with one parent, what I mean by child here is just anyone, both children under the age of 18 and adults living with a parent. Anyone living with one parent with poor mental health is 76% more likely to die by suicide compared to individuals living with parents with no mental health problems. This was higher for children living with 2 parents with poor mental health and increased again for children under the age of 24 years. So looking at children and young people in particular, what we found was children under the age of 24 who lived with 2 parents with poor mental health were 2.8 times more likely to die by suicide compared to their peers that were living with parents with good mental health. And this is a stark realization and something that may not actually be that new, but for the first time we were able to look at this at a population-wide level. And from this, our recommendation is that mental health services should have a family focus. The children living with adults with poor mental health are also at risk themselves. So when an individual presents with a mental health issue, it's important to not only treat the individual, but treat the family. And that might be a bit of blue sky thinking when we're in a crisis situation right now where provision of mental health services are already stretched. But when we see figures like this, where we see that people living with parents with mental illness are themselves at such a great risk, it's a perfect area for intervention. Our next finding was that 2/5 of people who die by suicide in Northern Ireland were known to social services in childhood. And this was a study that linked social services data to a range of health data sets and mortality data. And what we found was that individuals with childhood contact with social care comprise about 11% of the Northern Ireland population, yet they account for over 39% of all suicide deaths, so almost 2/5 of all deaths. And what we mean here by contact with social care is that the individual was not necessarily a looked after child or in care, but known to social services as a child in need. So when we see this mapped out for the whole population, about 11% of the Northern Ireland population had childhood contact with social services, but they represent about 2/5 of all individuals who die by suicide, and about 3/5 come from everybody else. So our recommendation from this is that social services provide a nodal point for intervention in that, of course, individuals known to social services have an increased need when it comes to their mental health requirement. They are exposed to more adverse childhood experiences than those not known to social services. But if we're trying to prevent death by suicide in a population, and it's difficult to identify who may benefit most from interventions, one suggestion is that we know children known to social services, not just those in care, but those known to social services for a variety of reasons are at an increased risk. And when we're thinking about intervention research or policy planning, we may think, well, this is quite a large population to target. But we've found then if you want to, within that population, focus interventions more readily, young adults who are care experienced are at a higher risk of self-harm and suicide ideation than those who aren't. So within children known to social services, we have children that are known but remain in their own home and identified as a child in need, and we have children that are removed from their own home and placed in care of either foster care, kinship care, or residential care. And these are usually what we think of when we think of children known to social services are those children that are looked after. And currently children known to social services at any one point in time account for about 4.8% of the child population in Northern Ireland, but represent almost 1 in 5 of all children who experience mental ill health. So this small proportion of individuals that are known to social services have a larger proportion of them in contact with mental health services. When we look at children that aren't just currently known at one time, but have been known at any point over their childhood, it represents about 17% of the population, and then about half of those who experience mental ill health. So although children may become known to social services and then they are released from care or returned to their own home or no longer require support of social services, these individuals are at a higher risk of mental ill health than individuals never known to social services. And these children are 52 times more likely to present to emergency departments with self-harm or ideation compared to children with no contact with social services. And again, let's say focusing interventions on all children known to social services seems like too much of a demand. Well, then children who are in care or who have a history of being in care may provide a nodal point for intervention. Finding number 4, sorry, I'm just flying through these findings here, but finding number 4 was that children referred to social services and deemed not in need are 4 times more likely to die by suicide than those never known. So this, like I mentioned previously, we have categories of individuals who are known to social services. And classically within research with children known to social services, we focus on children who are in care, known to social services and removed from their current home. But within the categories we have, firstly, individuals that are never known to social services. Category 0, you've never had any contact with social services throughout your whole 18 years or 17 years of childhood. Category 1 is you referred to social services, but deemed not in need. Your concern was raised, there was an investigation done, and it was deemed that social services didn't have to intervene on your welfare. Category 2 is you were referred and deemed in need, but were allowed to remain in your current home. So this is where you have legal orders, supervision orders, you stay in your own home, but social services do have some sort of interaction or help and support. And the third category is referred to social services and removed from your current home, placed in either foster care, kinship care, residential care. And this is what we tend to think of when we think of children known to social services, but we have a range of different categories as well. This category, referred and deemed in need remain in your own home, is difficult to identify from research that isn't administrative data research. Children may be known to social services in their own home, but not know themselves that they actually have interaction with social services. And whenever we do surveys and ask adults about their social, interaction with social services in childhood, this group will certainly know that they had interaction with social services. This group may not. And this group will definitely not. You may not know yourself that a concern was raised to social services about you. And for the first time ever, administrative data has allowed us to identify this new at-risk group. What we found was that risk of death by suicide increased sort of stepwise along these groupings with level of involvement with social services and was still strong in those deemed not in need. So this is a previously unknown high-risk group. This is a group of individuals that have engaged with services, that a concern was raised about them at some point during their childhood. And although they may not have been in need of social services help, they're in need of something, because we can see that throughout their life course, they continue to have poor mental health and an increased risk of death by suicide. So when it comes to identifying who may benefit from interventions, these individuals that are referred to social services and deemed not in need of their support may require some other kind of support. Finding number 5. Individuals who present to emergency department with ideation alone are over 10 times more likely to die by suicide. So emergency departments, in our opinion, are vital in our fight to reduce death by suicide. And within the Northern Ireland Self-Harm Register, we have information on individuals who present to emergency departments with a range of different self-harm behaviours, through to also just thoughts about self-harm. And this is what ideation is, where you're thinking about hurting yourself or thinking about taking your own life. And again, information on individuals who have these thoughts are difficult to get from conventional survey research. And also, it's difficult from some administrative data that we have where we're just able to look at hospital presentations for self-harm. What's unique about the Northern Ireland Registry is that it collects information not only on presentations for actual deliberate self-harm and injuring yourself, but individuals who present to emergency departments with just thoughts of self-harm and may not have any intervention by health services at all. But it's important that they've made contact and they've reached out and have shared information that they are feeling like they want to hurt themselves or want to take their own life. This research doesn't just have a child focus. We're looking at individuals across the life course who present with emergency department or present with ideation. And what we found was that presentations with ideation alone, so just thoughts of self-harm without actually harming yourself, represent an important potential intervention point for a hard-to-reach vulnerable population. These guys are 10 times more likely to die by suicide than individuals who never present to emergency departments. Unlike self-harm, there are no NICE guidelines or clinical guidelines for the management and recommended best practice of care for individuals who present with ideation. They represent a large proportion of individuals who are turning up in our emergency departments, and we know these individuals are more likely to die by suicide, but there are no clinical guidelines or treatment guidelines for what we do with individuals who present like this. So the research group here who carried out this particular study, led by Dr. Emma Ross, are looking to develop now clinical guidelines around the management of care for individuals who present with ideation. So although administrative data research has shone a light on this group, the next steps involve development of guidelines, development of intervention research, and we can only go so far with the administrative data that we have available. Finding number 6. Almost a quarter of young people who died by suicide in Northern Ireland had presented to emergency departments with self-harm. So 22.6% of young people under the age of 24 who died in Northern Ireland had previously presented to emergency departments with self-harm or ideation. The majority of people who die by suicide are not known to services or do not have any previous history of mental ill health. However, for 22% of young people, they had been previously in contact with emergency departments with self-harm and ideation. They were known to us. They were presenting to us, showing that they have a problem and a need. Within this group, to try and identify, well, who within the individuals who present to emergency departments are more likely to go on and take their own life. It's difficult to ascertain. There wasn't a clear trend in that, but we were able to see increased suicide risk in males who present with self-harm and in those using more violent methods of self-injury. Things that you may consider would be more of a suicide attempt than self-harm. And this again highlights that emergency department is a prime point for intervention. Although some individuals, we cannot predict their pathways towards death by suicide, for others, the signs are there and they're presenting to services and letting us know that they need help. And presentations to emergency departments are a prime example of this. I'm flying through these guys, so hopefully there's lots of time for discussion at the end. Finding number 7 is we did some work looking at the impact of COVID on presentations with self-harm and ideation. And during the pandemic, there was a major concern that there'd be this tsunami of mental ill health, that we were going to see an increase in rates of poor mental health in the population because of the pandemic and its associated lockdowns. So what we found was a number of individuals presenting with self-harm or ideation dropped significantly at the beginning of the pandemic, just for the first few months. The very first lockdown, we saw a sharp decrease in presentations to emergency departments before the trend returned to as expected for the next 2 years. We didn't see this massive increase, and we didn't see a decrease either. The first 3 months, we saw a decrease because there was a stay-at-home order and individuals were told not to present to emergency departments. But as rates crept back up again to normal, they stayed at normal throughout the pandemic and even post-pandemic. However, when we looked in more detail, there were inclinations that in those aged under 16 years, numbers presenting with self-harm or ideation increased slightly above expected levels. So we did some modelling to see, well, if the trends were to continue as normal, how many presentations would we expect to see? And we saw that in the very young, children aged under 16 years, we saw slight increases, slightly higher than expected levels of presentations, but very, very slightly bordering on statistical significance and bordering on clinical significance. We didn't see this massive increase. However, COVID potentially had the biggest mental health impact on those under the age of 16 years. I think this is reflected in a bunch of research that's been carried out since then. And I think logically, given the impact that it had on our children more so than adults, it makes sense that COVID had the biggest mental health impact on our young people. So given the wealth of findings that we've created from these papers, we've decided to list some recommendations and put them together in a policy brief to identify how we can help use the information that we have found from these studies in order to help inform suicide prevention strategies in Northern Ireland. And our recommendations are, first of all, that EDs present and a missed opportunity for intervention. Like I mentioned, almost a quarter of our young people who die by suicide in Northern Ireland have presented to emergency departments with self-harm and ideation. They're letting us know they need help and we are not responding effectively. Social services presents a missed opportunity for intervention. Children known to social services are much more likely to present with self-harm and ideation and also to ultimately die by suicide. If we're not able to target interventions at the entire population, at least identify individuals that are known to social services, as we know these guys are at an increased risk compared to those not known to social services. Those deemed not in need are a hidden risk group that we knew nothing about before. Although they may not need help from social services, they clearly need help and support in other ways. And there is a need for clinical guidance around the management of self-harm and suicide ideation in clinical care, because these individuals are at an increased risk of going on to take their own life, and we need to serve them better. I did fly through all of this in record time, but I just want to highlight that this work reflects not just work from me, but from an entire team of individuals who have worked together across academia and also our data providers and our data custodians and our steering group who have helped to inform the direction of the research questions that we ask. Happy to take any questions at this time, and apologies, Fatini, for being well under the hour allotted slot that we had for this. Thanks.
Yeah, no worries. Thank you. It's best like if there's time to discuss rather than finish like 2 minutes before the end. So I see that like the Q&A. Oh, is it answered? Yeah. So there was a question about the slides, but Gida has answered that the recording will be available. I don't think there are any other questions. So maybe I can ask a couple of questions to get people like started.
Sure.
So I'm trying to think like, because as you said, like there were a lot of interesting findings. Oh, see, somebody got me. So yeah, there's a question about why do you think there was a drop in suicide ideation during COVID?
Yeah, so the initial drop we saw was just for the first 3 months. And this was, again, it's presentations to emergency departments with ideation or presentation to emergency departments with self-harm. So the ideation and the self-harm may still have been occurring. It's just individuals weren't taking themselves to the emergency department during that time because of, I think if we can all try and remember back to the very first lockdown, and the kind of fear that was around about going near a hospital, and you were told to stay away from emergency departments except for in case of, in case of extreme emergencies. And I think people just took heed of that and didn't present. But as the after about 3 months, the levels returned to normal again. So I think it was just the initial shock, and perhaps at that time their individuals were self-harming less because there was this sort of collective common enemy of a global pandemic. And we people weren't sure what was going to happen. And especially around that first month or two. Before then, things returned to normal. We've seen the same patterns when we looked at uptake of prescription medication. We saw the same where there was a strange behavior for the first 2 or 3 months, and then things returned to normal again. So I think if we thought that the COVID pandemic was having an actual impact on rates of self-harm and suicide ideation, we would see it continue to increase over the course of the pandemic and beyond. But what we've seen is that things have returned to normal. So I'm not sure. It's not to say that the pandemic hasn't had an effect on mental ill health or suicide ideation or self-harm behavior. What we're saying is it isn't reflected in presentations to emergency departments, so perhaps it's reflected elsewhere.
Did that correspond to a raise, like there was a drop in self-harm, but a raise in like death by suicide, or is it too small numbers to look at that?
Well, we haven't also seen an increase in death by suicide in Northern Ireland in particular. Again, the rates have been as expected. So we were kind of thinking, was it that these individuals weren't presenting to emergency departments? They were just and their self-harm behavior was worsening and resulted in an increase in death by suicide. We didn't see that either. So we're not 100% sure what happened, but I think what we can say is overall, it's difficult to tell from the administrative data, but also that we're not seeing these massive increases that we were expecting at the beginning of the pandemic.
Yeah. Oh, there's another question. So, what are your thoughts on the kinds of interventions that you think would be effective at these touch points, like missed opportunity points?
Yeah, I mean, I think it's difficult to think. I'm not an intervention researcher, but it's difficult to think of particular interventions that may be beneficial in these areas. I think certainly from the social services or interaction with social services being a nodal point for intervention, the thought would be that there needs to be a policy change on the amount of mental health support that are provided to children known to social services. And at the minute, it's minimal. There are none, and it varies in Northern Ireland, sort of trust by trust, what's available. So the recommendation there is that, when a child is known to social services, mental health support should be a given, and it is mental health support provision for children known to social services is better in England and Wales than it is in Northern Ireland. So, it's more of a policy recommendation from that side. From the emergency department point of side of things, I think that's a prime opportunity for interventions in terms of next care or engagement with services. And there have been a lot of interventions rolled out in Northern Ireland, things like the Card Before You Leave scheme, and that was that every individual who presents to emergency departments with self-harm or suicide ideation will leave with an appointment to see a mental health professional before they leave that emergency department. And that scheme doesn't exist anymore. So I don't know whether the recommendation is let's implement that again and evaluate it effectively to see if it works. But I mean, I think the question would be, are there any intervention researchers who are aware of interventions that are delivered in emergency departments or in primary care or elsewhere that are effective? And if so, this research can help direct where the interventions are best targeted, but an intervention researcher would be best to tell us which interventions they think might work. So if you guys have any recommendations, let me know.
It is the same that the card was stopped. When did that happen? Was it during the pandemic or before?
Before it kind of each trust kind of stopped at different times, and it was more to do with the funding provision, not to do
Okay.
with the fact that that was deemed efficient or inefficient. And again, it comes back down to the amount of the funding for mental health services in Northern Ireland again being much less than it is in England and Wales, and Scotland. So I think if we're able to identify and highlight areas where intervention would be most beneficial then and most cost effective, I think that's where we'll see real change.
Yeah. Yeah, so there's another question. In any of your studies, were you able to find any differences related to ethnic groups and which groups were more affected?
The short answer is no. So ethnicity is in Northern Ireland, ethnicity data is really only available from the census. And we currently have a project where we are linking the census data to the self-harm registry data to explore just that, to explore um, differences in risk by vulnerable groups. So this is or previously hard to reach groups or underserved groups or however we want to say. So it would be ethnic minority groups in Northern Ireland, religious minority groups in Northern Ireland, and members of the LGBTQ community, members of the Irish travelling community, and all that kind of information is only available really in the census. So we have a project underway, and data linkage is ongoing, but we don't have any answers to that yet. So I'll come back next year and tell you the answers to that.
Yeah, so do you also conduct research using population cohorts or finding consistent with administrative data?
Again, no would be the short answer. So the data, the projects are all focused around sort of distinct linkage projects where we're creating our own population cohorts from administrative data and answering research questions about them. We don't then sort of compare it to things like the Millennium Cohort Study or findings from any of these other longitudinal cohorts. Um, I think it would be interesting if we did, but there's a new child cohort study that's just been launched in Northern Ireland that's beginning this year, that will allow us to do that from a Northern Ireland population. But I think when we look and compare the population cohorts, we also have to take into consideration that we're not comparing apples and apples here. We're comparing a Northern Ireland population potentially to an English population or a Welsh population, and there may be some differences that are unmeasured there.
Yeah, it is tricky. Like even those studies that have like data from across the UK, like the Millennium, is still like very small numbers in like Northern Ireland and smaller parts. So do you find differences by sex? So I'm guessing that's in general.
For
Uh,
everything, yeah. In all of the studies, yes, there are differences by sex in that uh, men are more likely to die by suicide than women. Even um, when we look at individuals who present with self-harm and suicide ideation, it's the men that are more likely to go on and take their own life. Um, Interestingly, in Northern Ireland, we see um, about a 50-50 split in terms of individuals presenting with self-harm, the gender split, whereas I think across Great Britain there tends to be more women presenting with self-harm than men. But in Northern Ireland, we have both men and women presenting with self-harm, and both men and women presenting with suicide ideation in kind of equal measure. So the lesson that we can learn from that is that I suppose, men's mental health in Northern Ireland is particularly it requires particular focus. But when we try to explore predictive factors, and when we look at things like children known to social services, is it women known to social services or men known to social services that are more at an increased risk? The general trend of men are more likely to die by suicide than women persists throughout. Um, but there's some interesting sex differences in presentations for self-harm and suicide ideation when we compare to the rest of the UK. I hope that's answered the question. I'm not sure it's very general.
Yeah, no, I was wondering on that as well. So because you said there were differences by gender in that population, but does that population differ from like the general population? So are they more likely to be male, or is it just again an even split? So being in contact with services and
Or being in contact with social services is an even split. Presenting with
okay,
self-harm is an even split. And I think when we compare to other places across the UK, you'll be known to social services is an even split. But presenting with self-harm in GB, you tend to see more women than men, but Northern Ireland's slightly different than GB and Ireland in that we tend to see an equal split between men and women.
okay. Oh, yeah. So what would you say the greatest challenges are with using administrative data for psychiatric research, and any tips to overcome these challenges?
Um, there's a few challenges. I suppose the the one I'll speak about. Okay, so there's one about data access. Accessing administrative data takes a long time. Getting access to permissions to do the linkage, to all of that takes a long time. Once you get the data and do the analysis, it's quick and easy and relatively cheap. But the processes to gaining access to this takes such a long time that by the time you're asking questions of the data tends to be out of date. So that's an issue that is across all administrative data research. Doesn't mean that we shouldn't do it. It's just something that we can do. I suppose we're working towards streamlining those processes. And the more individuals that use administrative data for research and the more times this is done, the more it becomes less of a novel new thing that data providers and health trusts are afraid of. And they're like, yeah, absolutely, take the data and do this because we know that we're going to get good return for our investment here in terms of policy relevant and service relevant research. So the advice for that is just keep doing it. And even though it takes a long time, it's important that individuals keep pursuing it because we have to show case studies of why it's valuable in order to prove to individuals why we should speed up the process. But the biggest limitation, I suppose, or challenge is methodologically around who we can actually identify from administrative data when it comes to psychiatric research. And we are identifying individuals who are in crisis and have already engaged with services. So we miss um, a lot of the population who we can't capture from administrative data, from the administrative data sets that we currently have. So at the minute, the administrative data sets that we currently have that we can use to identify psychiatric ill health are things like prescription medication data, admissions to psychiatric hospital, presentations with self-harm or ideation. And these things are all individuals that have sought help and presented to services. What we don't have data on are interaction with counselling services. We don't have primary care data for presentations for mental health symptoms. So I think everything that we do is on the far end of extremity and doesn't really reflect the magnitude of mental ill health in the population or those common mood disorders that are more difficult to identify from administrative data. And what that means is that we need to understand that in order to have further upstream interventions because we're looking downstream at the result of of years and years of mental ill health. And we can start to intervene slightly before that, but the more information we have about a person's journey into mental ill health, we can start to identify um, potential areas where intervention is important earlier in their lifespan.
So are these data with like as you said, like contact with services, but not like getting a diagnosis, which is more clinical? Are they not available, or is it hard to link in Northern Ireland? Is it
You mean
not
the
non-pharmacological treatment, for example?
yeah, so
Again, they have sick treatment and yeah.
yeah, they're technically there, but just the legal permissions to access the data don't exist. So they've never been accessed for research purposes before. So it's like the first time we used prescription medication data as a proxy indicator of mental ill health was about 10 or 11 years ago. And it took about 3 or 4 years to get the permissions from the data custodians to access that data, and now it's used regularly by research groups all over the UK. So we're at the point now where we're asking for um child and adolescent mental health services data in the first instance, and then adult mental health services data in the second instance, to get access to that. But it's just a long process in data custodians agreeing from each of the health trusts that they're happy to share that information for research purposes. The biggest challenge in all of this is the timeline and the legal constraints and data sharing agreements, and all of this stuff. I mean, any provision of services will hold data for that service. So we know the data is there and exists, but getting permission to access it is where the stalling points are. And do I have any advice on what to do with that? If I did, I would know what to do. It would be great if we could speed things up. I think it's I think all we can do is keep promoting the excellent findings that we've got from previous research using administrative data to show the value of these health trusts providing this information.
Yeah, and it takes like a lot of patience, like you did. I know, like you presenting the results, and it seems like the data was there, but it was a journey to get access to like the social services data.
Yeah, absolutely. I mean, all of this work that we presented very quickly in about 20 minutes is the reflection of about 7 years of research and data, a lead in of about 3 or 4 years of before we even get data to work on, and then getting data and cleaning it and doing the analysis and getting published. So when we get the data, it's quick. And once you've done something the first time, the second time's easier and the third time's easier again. So like I say, the likes of our prescription medication data, our hospital data, our self-harm registry data, or deaths data, all of that stuff now is super easy and quick to link because it's been done before. But the mental health services data has never been accessed before, so this will take a bit of a long run in, and then once we get it, things should
Yeah,
be
and
much easier.
has there been any shift? Because one of the studies you presented was on during the COVID period. So I know that during that period, a lot of studies came out because like everybody was focusing on that. But did that result in any change of like attitude in terms of getting access to, so giving access basically to the data? Or was it
Yeah,
during COVID and then it stopped?
well, it was during COVID and then it stopped. Because during COVID, we as the research team got much quicker access to the self-harm registry data than before, whereas before we had to wait sort of they create and collate data quarterly, and you'd have to wait to each quarter to get an update. But we got weekly
Okay.
updates during COVID because they were happy for you to look at things quite quickly. And then whenever that study was finished, they were like, no, 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 you still have to go back to
Oh,
quarterly again.
that's the same.
Yeah, so it took a step back, but I think what it did was it opened a lot of people's eyes to what's possible. Um, and there was sort of emergency legislation, given that it was, again, legal things that I never thought I would be one bit interested in. But whenever you get into the world of administrative data, you have to understand where the stopping points are. And as researchers, I'm just looking at it going, the data's here, why can't we get access to it? We'll be able to answer really important questions about the population. We'll be able to potentially save lives here. Why won't you give us access to the data? But it's surrounded by legislation, which I suppose ultimately is for the protection of our data whenever as us as users of these services as well. But there's emergency legislation that applies to COVID, and when the pandemic officially ended, that stops. But what I think it has done is, yeah, it's opened people's eyes to what's possible. So whenever we're going forward now and having discussions, people are a lot more receptive. And I think post-pandemic, we've noticed that people are a lot more receptive and a lot more aware of what data is available and how it can be used. So not a complete loss, but yeah, we've kind of took during COVID we took about 5 steps forward, and I think we only took about 4 steps back. We're still a bit further ahead post-COVID than we were pre-COVID.
Yeah. So I'm wondering because I know that the data we're talking about cover like a long period of time.
Mhm.
So I was wondering if during that period has been any change in terms of like accessing like services and whether you'll be able to see if that impacted like poor mental health and self-harm. So because I know that it's like does it start from like the 80s or the 70s? So you cover like a big period of time.
Yeah, the social services data, it is over 30 years worth of data, but the self-harm registry data is just about 14, 15 years old,
Ah, okay.
from about 2009. So we're able to look at sort of trends over that time. And we're currently doing some work at the minute that's an in-depth exploration of trends and projections. And over that time, there have been lots of different sort of service interventions, like we mentioned, the card before you leave scheme and other particular interventions in particular health trusts that we're going to see if we can use this self-harm data to try and evaluate to see like a natural experiment of sorts where like, well, this trust offered this, did that result in any change in our presentation pattern? It's quite crude. It's not a sort of one-to-one, did this person receive this intervention program and did it have an effect? But it'll let us see that, globally at the population level, at that trust level, if a particular service was available in one particular trust, did that make a difference to overall rates of things like recidivism or death by suicide? So we're doing some work on that at the minute to see if there have been these changes over time and how people interact with services and presentations to emergency departments in particular.
Yeah, I was thinking of like across time and maybe like across trusts because they're bound to be differences.
Absolutely.
Yeah, oh, that's good. Trying to think. Yeah, I was wondering because you used the term, you might have mentioned it, but I might lost track of it. But you were mentioning about like children, so I was wondering, what is like the age range for the outcomes? Because we're talking about like self-harm and suicide. So was there any like high period of time that was more at risk, like adolescence or like transition to adulthood, like those young adults that were more at risk?
Yeah, so I suppose it's different for different exposure groups that we're looking at, and when we use the term children, it's meant different things. So I suppose the confusion mainly comes from that first study that looked at living with a parent with mental ill health. And when we use the term children for that, we just meant any child, whether you're 0 or 60 or 70,
Okay.
if you were living with a parent. And that's was explained sort of in the paper, but maybe not explained very well in my slides. But other than that, we tend to use children to be under the age, like 17 years and under the age of 18, and then particular focus on young adults 18 to 24. And especially when we're looking at children known to social services, because that 18 to 24 age group is a real difficult transition period for a lot of individuals who are aging out of the system, who are aging out of the statutory requirement for care and support.
Yeah, that I was thinking about too. Yeah.
So we do see increases in rates of presentations for self-harm in children known to social services at age 18 and 19. So there's a great spike. These children and young people tend to be higher than the general population anyway. And then as soon as they turn 18, there's a big spike, which we think relates to the fact that this is a difficult transition period. One of our researchers is doing a new piece of work at the minute, just looking at that transition period and what happens when children are aging out of care in terms of their interaction with services, in terms of their living situation, if they're registered homeless or houseless, and their interaction with the justice system to see what happens to these individuals, young people, as they're aging out of care. Because there are arguments for providing support up until the age of about 24. But
But
again,
during that transition, does like everything stop basically the moment they turn 18, or is it gradually?
no, everything stops. So I mean,
Okay.
legally, but it depends on each individual's journey, and each individual child's journey is different. But when a child turns 18, everything else considered well, they can leave the care system, and their foster care providers or kinship care providers no longer get financial support for them.
Okay.
So for many of them, they are homeless. They are essentially kicked out on their 18th birthday. Now, there are support services available in terms of helping young children and young people age out of care, ensuring that they've got emergency accommodation, they've somewhere to live, they're not in the streets, helping them to, support finding housing for them, etc. But it's whether or not children and young people are engaging with this service, whether or not it's useful or not, because it's their choice. Once they turn 16, they can choose to leave. Once they turn 18, there's no legal requirement to look after them anymore unless they're in full-time education or have additional needs. So a lot of these children will choose not to engage anymore, whereas some will. And it's just a really difficult period, and one I think that produces or is one of particular risk, critical risk for these young people, and a prime time to get them on the right track and ensure we don't see exasperation of their mental health symptoms.
That makes sense. Yeah, I was hoping the answer would be like it's a gradual increase,
Yeah,
but
yeah.
yeah.
I mean, we do a lot of work with experts by experience. So we have a group of care experienced young people who help sort of advise on the research that we do around using their data. And they'll tell you themselves that everyone's journey is very different, it's vastly different. And there are support services available, but again, it's how much they engage. And every child coming up to the age of 16, 17 is well aware of that impending 18th birthday. And they can sort of seek out support as to what to do before then, and services are offered, but it's not something that's mandatory. And I think even before a child turns 18, there is that anxiety that begins when they're 17 and they know that they'll soon be falling off this cliff edge of care.
Yeah. I'm trying to think of a more positive question to end it. But yeah, I'm sorry. So yeah, so maybe you want to talk a bit more about that piece of work you said that is working more with. So is it like qualitative or is it again with administrative data?
Which works this?
I said the one you mentioned that is currently underway, which is like more about the one you mentioned now. Sorry. To learn
So,
more. Sorry.
so you mean involving experts by experience,
Yeah.
or
Yeah.
yeah? So yeah, involving experts by experience is more I suppose it's not the research itself, it's just that we're co-producing the
Okay.
research together. So the idea is that nothing the people we're looking at individuals' data, and in order to better understand the patterns that we're seeing in the data, we need to talk to the individuals themselves. So we have what are called a data research advisors group, and we have one for all of our work package around children known to social services, and it's a partnership with a local charity called VOIPIC, which is Voice of Young People in Care. And all the young people that are involved in this data research advisors group are care experienced, and they have helped to shape the direction of the research questions that we ask. So they'll be like, we want to know this, we want to know this, we want to know this. Can you do that from the data? And sometimes the answer is no, we can't do that from the data. And sometimes the answer is, yep, absolutely, we can. And they're interested to know the results, and we feed back to them when we get their input to be like, why do you think this is happening this way? And why do you think we're seeing these patterns? And they can offer insights that we can't offer. And in particular, what I didn't present here is we saw great differences in higher rates of mental ill health in children who are in residential care compared to foster care, compared to kinship care, and they're able to provide great insights into what residential care living is like, and why that might be the case that we just as data researchers wouldn't know. So this partnership's been really effective, and it was kind of a pilot project to see, could we involve people in administrative data research where it's difficult because access to the data is behind strict sort of firewalls. You have to be an accredited researcher to access the data. You're in a safe room. You're on computers that aren't connected to the internet. The outputs have to be cleared. So it's very difficult. It was like, how do we engage people in this? So we thought we'll engage with some young people. We'll tell them all about it openly. Well, this is how admin data research works, and see if they're on board and happy to help, and they were. So we're doing a piece of work at two other projects at the minute, one focusing around homelessness, using data from the housing executive on individuals that have registered as in need of housing, and on the prison population, looking at the mental health of our prison population, self-harm, suicide risk after leaving prison, and sort of pathways into prison in terms of interaction with social services, etc. And we're going to try and replicate this experts by experience approach with them too. So we're going to have a group of individuals who have experiences of homelessness and a group of individuals who have experience of being in prison, to help advise us on what questions are important to them, and what questions we should be asking of the data, and how we interpret our results. So I think it's the way that we plan to work moving forward, because it not only helps us understand the data properly, but I think it makes sure that we're asking relevant questions of the data and not just data that are or questions that are of interest to academics. That's
Yeah.
a bit of a more positive note to end on.
So yeah, that's great. Yeah. Thank you again, Aideen. So I just want to, like, I know that we're on time. I just give a reminder that we have posted that in the link with the YouTube channel where the lecture will be posted, and where you can find like previous lectures from the series. And we have also shared the mailing list where you can find more about the Wolfson Center upcoming event. Also, just like a reminder, I know it's far ahead, but the next lecture will be by Professor Michael Unger, and will take place on the 5th of February, and will be focusing on mental health resilience. So yeah, I think we're on time, and I will close today's session here. And thanks again, Aideen, for giving this presentation.
You're welcome. Thanks for the invite, guys.
Yeah, thank you.